Ladies and gentlemen, Franz, Maci, thank you very much for inviting me again to this excellent meeting. I get the feeling, and I'm here for the third time, I get the feeling that the meeting is getting better and better from every second year to every other second year. And I'm very happy because I learned a lot, even so that the average number of radical prostatectomies in the US is 3 per year. That was very impressive. I thank very much Mrs. Carlson who came up with the data to show us that we are not that bad in Europe. Now we are going back to the old stuff, open surgery, but I hope one day I'm keen enough to do this kind of surgery even with the robot, or even so I'm not brave enough to do it right now. So the question is, does salvage lymphadenectomy is a treatment option in prostate cancer recurrence after the patient received a certain type of treatment? So what are we looking for? We are looking for where are the positive lymph nodes located, and I'm talking a little bit about the technique of salvage surgery because it's different from what most of the people probably in this room believe it is. What about the biochemical recurrence free survival in the different groups, in the different patient groups, concerning also the positive lymph node locations and the cancer-specific survival? We were discussing it yesterday. I'm not talking about the overall survival because I think the most important issue is the cancer-specific survival after salvage lymphadenectomy in the long run, even so in hormone-refractory prostate cancer patients. So most of you who are dealing with this kind of problem, I mean everybody hopefully is dealing with this kind of problem because you see those patients who show up after radical prostatectomy, after brachytherapy with a recurrent PSA. They probably know this important paper from Chade who was talking about radical prostatectomy after radiation therapy of prostate cancer, and they demonstrated that about 75% of the patients who receive a salvage radical prostatectomy after radiation therapy will improve and will actually benefit from this type of surgery. I think what we have to finish immediately is to tell the patients that if you had received radiation therapy, we are not able to do surgery on you. There is no problem to do that. It's more difficult, yes, but there is no problem to do surgery on irradiated patients. What about the imaging? Everybody is using it and everybody is talking about choline PET CTs, and I think there was one paper yesterday, you mentioned it, that the choline PET CT is insufficient, unfortunately. There is no image that actually helps us, and I just took 3 papers from Schiavina and Passoni, who demonstrated that the positive predictive value is something between 24 and 41%. And we also did it in comparison with our very extensive salvage surgery, and we found, just to look at the side where we found the positive nodes in comparison to the choline PET CT, which was done prior to the surgery, of course, that we found a positive predictive value only in 56%. If you really look at the locations, we are somewhere around 27%, which is really rubbish. So it doesn't help you really. On the other hand, it's a clear help if you want to draw the indication, I do the surgery on the patient, yes or no. But we have to wait for better images in the future, and they will come definitely with the MRI, I believe. But it's not the time to talk about this subject today because what we have is what I just demonstrated. When you do an extended pelvic and retroperitoneal salvage lymph node dissection, we have to go transperitoneally. That's the only way to do this kind of surgery properly in these patients. We were talking, when we were talking about open versus robotic surgery, we were talking about the quality of the surgeon. It's also the quality of the technique. So the only way to do a salvage lymph node dissection is go transperitoneally, because you find lymph nodes all the way up at the aortic bifurcation, you find them in the common iliac artery, you find them in triangle of Marseille, you find them presacral. And I show you where we found the positive nodes and what are the figures are where you find most of them, independent what the choline PET CT demonstrated beforehand. There's, I think, a very, very good paper that was published in 2012, and they demonstrated their results and presented their results at the EAU meeting in 2013. The follow-up of their patients that was actually presented by Jilk from the German group in Freiburg, from Mr. Schulze-Seemann, and they actually did perform salvage lymph node dissection, extensive salvage lymph node dissection, as you can see it over here. In 50, I think the overall was, 52 patients, and 27 were followed even with radiotherapy in addition to that. And the overall results were quite interesting. They are not promising, and I tell you why, but they are interesting because they showed that the biochemical recurrence-free survival rate, let's look at 3 years, is something around 17.5% without any additional treatment. We are talking about no additional treatment in these cases. If the lymph nodes that were positive were only located in the pelvic region, if you had lymph nodes which were also located retroperitoneally, so above the bifurcation, then the results get even worse. After 3 years, we are talking about 5.8% of patients who do not show a PSA recurrence during the follow-up time. The problem is, probably, we do not know yet exactly, because the data are missing, the median number of positive nodes were 4. And there might be a threshold which is something between 2 or 3 positive nodes, and that clearly shows you still need, if you do this kind of surgery, also a selection criteria, which patient should receive this kind of extensive surgery and which one shouldn't. So what we did, we actually accumulated, or we collected all the data, and it was Zuardi from Briganti's group from 5 different institutions in Europe and 2 from the United States, and we came up altogether with 132 patients, which had a clear follow-up of patients with positive lymph nodes in a salvage surgery, so they're 81.4%. The other ones, altogether were 164, I believe, patients. The other ones, the pathologists didn't find the positive nodes, or the surgeons missed the positive nodes, so that also can happen. So what happened with the results? Well, what they and we demonstrated were that in the follow-up of 5 years, we had a biochemical recurrence-free survival of 40%. 40% of those patients who did receive the salvage surgery didn't show a recurrence in their PSA. But the problem was, and that's why the paper is not published yet, we are still discussing it back and forth, that some of the patients received anti-androgen therapy in between. And I come to this again later on. And probably most of those patients are from our group. But these were patients who were before they started, before we did the surgery, hormone refractory. And that's a very interesting issue, I believe. But the interesting part, why are these figures better? The mean number, or the median number of positive nodes were 2. So they also looked in the multivariate analysis, which are the significant parameters. And you can see that if you have a retroperitoneal uptake, it's a bad information, because this actually lowers the prognosis tremendously, and that was highly significant. The number of positive nodes, at least in this analysis of the 5 or 6 different institutions, shows that it's also a significant and important issue. So if you have more than 2 positive nodes, your prognosis decreases. And of course, if you have an immediate undetectable PSA after salvage lymph node dissection, was also a significant parameter. So all the other parameters, the PSA, the time of biochemical recurrence after radical prostatectomy, for example, were not significant, and according to our data, it's not an important issue. So the first conclusion I draw is that salvage lymph node dissection in lymph node positive patients after radical prostatectomy or after radiation therapy plus radical prostatectomy results in a 40% decrease or PSA drop below detection level. Of those, 40% remain biochemical recurrent free after 5 years, and the patients with a small tumor burden, probably below 3, it's not clear if this is the real figure, and the complete response to the metastatic surgery benefits most from the clinical progression. Unfortunately, the choline PET-CT fails to detect lymph node metastasis in prostate cancer recurrence. What about our results? We actually did surgery, we analyzed 54 patients so far. We did so far almost 90 patients. And the problem was with the publication that we always got the answer from the reviewers that the number of patients is too small. But who actually is doing this kind of surgery and has more than 50 patients? I don't know anybody. And that's the problem. But anyway, we made it, and it will be published in April this year. So what we do is I demonstrate you 45 patients who underwent salvage surgery between January 2004 and July 2012. Most of them just had radical prostatectomy. Some of them had radical prostatectomy and also radiation therapy, and there were only 2 who had primary radiation therapy, where we only did the radical prostatectomy plus the salvage surgery. So 43 out of 45 patients had a limited lymph node dissection initially. That's the biggest problem. So we do wrong lymph node dissection at the point of surgery, at the time of the initial surgery. We looked for the biochemical recurrence under anti-androgen therapy occurred in 80% of those patients. So they had anti-androgen therapy beforehand, and they didn't respond to it anymore. So the indications for salvage surgery was biochemical recurrence after of the prostate cancer, a reduction of the PSA doubling time, most of the time a positive PET-CT, even so at that time we didn't know that, it didn't help us very much, and of course exclusion of bone metastasis. And where did we find the positive nodes? And we always did a transperitoneal approach. We find positive nodes, for example, in the obturator area only in 2.5%. So the rest was found presacral, triangle of Marseille, 20% in the external iliac nodes. We found much more in the aortic bifurcation or even further up, and we found about 38% in the common iliac artery. So if you do this kind of surgery, we are talking about a complete different kind of lymph node dissection as we used to do when we do radical prostatectomies. What about the biochemical recurrence-free survival? The biochemical recurrence-free survival after 5 years of all patients was 42%. However, 88, that means 89%, received anti-androgen therapy during the follow-up. But remember, 80% of those didn't respond to anti-androgen therapy before the surgery. So they came, and the next step would be abiraterone or chemotherapy. If you divide these patients in those who developed bone metastasis within the first year, and sometimes the bone scan is not sufficient, and that's what happened to these patients, you see that we end up after 5 years with almost 50% who actually can be controlled with or without anti-androgen therapy in their PSA levels. And all of the patients who had or developed bone metastasis died within 2 years except one. One patient lived 7 years and he died last year. We don't know why he lived 7 years, but anyway, I don't think that we helped him with the kind of surgery. The interesting thing is, and that's always the problem, but it's something that is new, and then of course it takes time before the patients show up at your institution. Those who did good had an initial PSA when we did the surgery of 5.5, and those who did bad, of course, of the bone metastasis, had a very bad PSA at the level of surgery, at the time of surgery, even so they had anti-androgen therapy most of the time beforehand. When it comes to cancer-specific survival, we are talking about 81% after 5 years in those cases who were most of the time, or most of them non-responders to anti-androgen therapy, and none of the patients who did not develop bone metastasis died so far. We are now calculating the 8-year follow-up, and we have this by the end of this year. So what is the final conclusion? Extended salvage lymphadenectomy is beneficial treatment, but only in selected patients. So we won't do this kind of surgery in bone metastasis patients. Even so, some institutions started to do it with the argument we have new treatment options, additional treatment options, and we should also do the salvage surgery in those cases. I don't know. According to our data, we don't do it anymore. Salvage lymph nodes improves the response even to anti-androgen therapy in hormone-refractory patients without bone metastasis, of course. And the cancer-specific survival after salvage therapy is after 3 years, 92%, and after 5 years, it's 81%, which I believe is quite a good figure. But remember, we have no multi-center prospective data. which would be mandatory, and I would be happy if more people would start doing this kind of surgery. But believe me, it's demanding surgery. So when you start doing it, be prepared, do it open, because that's what we know most and best and can do. And be prepared that you probably at the beginning, particularly if you had a patient who had radiation therapy beforehand, that you probably need also the vascular surgeon to help you out if you run into an irradiated common iliac artery or something else. Thank you very much for the attention.
Thank you very much, Professor Jünemann. We shall now first hear Professor